Welcome, everybody. My name is Giulio Maria Corbelli. I'm a member of the European AIDS Treatment Group and also chair of the European Community Advisory Board. And I'm very happy to have this first webinar on patient-reported outcomes today. As you know, in clinical trials, in general, in clinical research, the patient-reported outcome are becoming more and more important and relevant because they try to capture some benefits or challenges that people are facing while in a clinical trial, or while, for example, trying a new treatment options. This is used more frequently also in HIV in clinical research. So we think at the European Community Advisory Board that the role of community there should be improved. We have some tools, of course, to measure the patient-reported outcomes, but are these tools developed together with community representatives? How are they established? How are the value also measured and assessed? So we will try to address all these questions with our presenter, who is Diana Barger. She has been working on patient-reported outcomes for many years. She's as origin, she's from the United States, but now she lives in France, where she works on this topic. So, Diana, if you are ready, I will leave the floor to you so you can start your presentation. Thank you very much.
Thank you, Giulio. So I'm really honored to be here giving this webinar about what we commonly refer to as patient-reported outcome measures and how they're used in drug development. So,
Diana, I'm very sorry. Before you start, I would like to give some instruction to attendees for asking questions, maybe, because I think this is relevant. You can find a question box on the control panel you should have on your right-hand side of the screen. So please type your questions in that box. I will read them, and at the end of the presentation, we will have some 10-15 minutes to discuss those questions with Diana. Sorry for interrupting you. Diana, go ahead, please.
So, as Giulio just mentioned, my name is Diana Barger. I'm currently a PhD candidate based at the University of Bordeaux and at the INSERM 1219 Bordeaux Population Health Research Unit. So my research is focused on health-related quality of life in people living with HIV, and I'm conducting this work in a long-standing cohort study of people living with HIV in southwestern France. Now, in order to understand health-related quality of life in the current treatment era, just as a reminder, 99% of those who are linked to care are treated, and 93% of them are virally suppressed. We're currently developing new technology to better collect self-reported health-related quality of life and other key patient-reported outcomes. Now, this work that I'm involved in is funded by an NGO in France called SIDA-Action and the French agency, research agency, the ANRS. Now, today we have a very ambitious agenda. I really want to thank all of you for your interest in this topic. And we've organized this agenda together with colleagues at EATG. Now, we've decided to address a few questions. What are patient-reported outcomes, and how are patient-reported outcomes measured? We'll take some time to talk about the tools that have been developed and how they've been validated, and specifically how patients are involved in this process, and what are the best practices. Then we'll conclude by talking about the different ways in which this specific type of data is being used in drug development and market access. Now, I think it's very valuable to set the stage with a very common scene, which illustrates quite well why patient-reported outcomes are important. So, you have a doctor, he comes back to the room after running some tests. He turns to the patient and states, "Congratulations, the tests were negative. Everything's perfectly all right." Meanwhile, the patient's sitting there thinking, this illness has affected my whole life. I have insomnia. It's affected my ability to exercise and eat. So we understand that these issues are perceived as relatively minor by the doctor in the scope of his larger healthcare needs, but that they remain important to the patient and often his or her quality of life. So unlike standard clinical outcomes, patient-reported outcomes give us unique insights into how a therapy can affect a patient. So individuals with the exact same health status, diagnosis, or disease might have different perceptions about how they feel, function, as their ability to cope with the limitations and the disability and other factors can alter their perception about satisfaction with life. So patient-reported outcome measures are important because they lead us in the medical sciences to be more focused on the real benefits that are achievable for patients. And they seek to overcome what we often refer to as an asymmetry in doctor and patient communication. Now, what are PROs or PROMs? So according to the European Medical Association, patient-reported outcomes are data reported directly by the patient on his or her own condition. And there's no interpretation by a doctor or anyone else. They're based on the patient's perception of disease and its treatment. So these findings can either be presented in absolute terms, or sometimes we'll see them as a change from a previous measure. So a change from the baseline measure in the case of a clinical trial, for example. Now, you often hear PROs or PROMs, and that's why I put them on the same slide, so that we have a sense what we mean by PROMs, which is really just the tools that we use to capture the PROs information. And this information has been used in clinical trials, and it's becoming more and more used in practice to facilitate doctor-patient communication, shared clinical decision-making, and then finally, it's starting to inform service delivery and redesign. And one of the reasons I think that we're doing this webinar is because there's this greater emphasis on the provision of effective evidence-based healthcare and the measurement of outcomes in the broadest sense. Now, this is true in drug development, but it's also true in terms of informing service delivery and health services. Now, we'd have a tendency to talk about generic or disease-specific patient-reported outcome measures. Now, what this really means is that some PROMs are designed to be general, such as the EQ-SANCT-D, which is a quality of life instrument that you might have heard of, and these have been translated into a lot of different languages, and they've been used extensively in clinical trials. However, there's a need often for disease-specific or condition-specific instruments, and these tend to cover areas that are relevant to patients with a specific disease. An example would be the Kidney Disease Quality of Life Questionnaire. Now, to give you a very concrete example, a patient-reported outcome measure for prostate cancer would have questions that relate to sexual function or continence issues, because to omit this would really be missing out on a lot of dimensions that are very relevant to the quality of life of these patients with this specific condition versus patients with something else. Now, in terms of how patient-reported outcomes are measured and used, now the questionnaire, the quick answer is that patient-reported outcomes are measured using questionnaires collected directly from patients. And the reason why using these questionnaires or survey instruments is important is that they allow for the standardization and reliable and validated measuring of patient outcomes or experience measures. In terms of when we generally use the PROMs, it's either in clinical trials, and one of the ways in which we generally think of PROMs in clinical trials as being most relevant is when there's little difference between to treatment protocols in terms of relevant clinical outcomes. So for example, a primary endpoint in a non-inferiority trial comparing an ART-sparing regime would be time to failure, but we might also see secondary endpoints such as quality of life or some sort of symptoms or satisfaction index incorporated into those trials. The second and third uses for patient-reported outcomes I alluded to earlier. It's clinical care and health service configuration. So in clinical care, these outcomes can be used for screening and monitoring and informing clinical decision-making. In terms of health services configurations, we see patient-reported outcomes being used to benchmark between different services and to ensure continuous quality improvement. One example it was a major initiative that was launched by the NHS to look at a few common procedures such as knee and hip replacements, and patients were then asked to report on their quality of life prior to the operation and after 6 months after, and then 1 year after, and that was monitored systematically on a national level. So we've talked a lot about, what these instruments are. Now it's important to look at their quality. So what makes a good PROM? Now, one of the reasons I'm here giving this talk is because we all agree that the most important thing is to have service users or patients involved in its development. And as Julio alluded to, this isn't always the case, or it's some instruments have been developed with more patient participation than others. And we'll get into a bit more detail about what to look for and what are some interesting and good examples of that. The next point is about evidence of validity and reliability. So this is especially, what we mean by that is validity. Does it measure what it claims to measure? And does it do this in a consistent fashion? So after talking about validity and reliability, we then discuss responsiveness. Now, responsiveness simply means the ability of the patient-reported outcome measure to detect change. And what I put in between parentheses is meaningful change, because there's a lot of ongoing methodological debates about what meaningful change actually is, and how do you quantify that when you're looking at a score. So I've put practicality here because in the early days, in the 80s and the 1990s, when a lot of these initial instruments were being developed and we were first getting interested in quality of life research, what we saw was a lot of evidence of extensive, valid, reliable, and even responsive instruments. So instruments that had very good psychometric properties. However, they were often 100, 150 questions, and so they weren't really practical. And in the second sort of wave of instrument development, what we saw was a lot of different groups trying to reduce the number of questions to make them practical. Now, the question of practicality is more and more important as we see the uses of the patient-reported outcomes multiplying, and also because we're increasingly relying on electronic collection of this data, meaning we don't want people to experience questionnaire fatigue. Finally, the last important point about what makes a good PROM is interpretability. This means do clinicians or researchers understand the meaning of the measurement? Now, we've put a lot of emphasis on the point that it's important for this to reflect what's important to patients, but we also need to close the circle and ensure that the information that we're generating in this standardized fashion can then be used by clinicians, by researchers, or by authorities. Now, I thought that it would be interesting to go through an example of the development of the PROQOL-HIV instrument, because this is one of the more recent health-related quality of life instruments that was developed for people living with HIV. Now, this was developed by a fellow team based in Paris, and the final psychometric study was released around 2012, 2013. Now, I would say that on the larger scale of other psychometric instruments, this shows a lot of evidence of extensive patient involvement, which is why I thought would be a good example to present for this webinar. Now, it's a simultaneously developed, multidimensional, HIV-specific health-related quality of life instrument that was striving to be sensitive to sociocultural context, disease stage, and treatment in the heart era. Now, I want to make a bit of take a bit of time to emphasize the methods that were used here. Now, this was a multi-year and sequential process that went from the development of a conceptual model and item generation, the development of a source questionnaire, linguistic validation, and then psychometric validation. And so this is really to show you the amount of time that it took to develop this instrument. And the initial field work, the first stage in this process, took place between 2007 and 2009, and the tool was actually validated in 2012. So it's fairly long. And this is how the authors summarized this process and showing all of the different steps. Now, we don't have time to go through every step in this process, but I wanted to highlight the different ways that patients are integrated into this process. So in the case of the PROQOL-HIV questionnaire development, they first carried out a literature review and interviewed experts in order to develop a patient interview guide. Now, this is where there was a fair amount of patient involvement, and we'll discuss this at length because, like I said, I think it provides quite a good example of getting patients involved in the process. Now, patients were interviewed in 9 different countries. All of these interviews were recorded, transcribed, and translated. Then they performed an initial analysis of the transcripts, and they took out verbatim sections, meaning quotes from the different patient participants, to generate what we call an item bank. So different issues, quality of life issues that came up and were expressed by the different participants. Now, the source questionnaire was then developed by, that's the second stage. The source questionnaire was then developed by HIV experts, and different drafts were reviewed. And then the 2 questionnaires were then back translated and then compared. Now, one of the challenges that we don't have time to discuss in detail is this point about linguistic validation. Now, I think it's still relevant to bring this up because it's something that a lot of people don't really know about or don't necessarily do, and especially when we're talking about pan-European trials, sometimes the fact that an instrument doesn't exist in another language actually makes it so that you don't use a better instrument and you keep using an instrument that exists in a lot of different languages just for maybe economic or just feasibility issues. On the other hand, it's still important to recognize that concepts tend to have slightly different meanings in each language, in each country, which is why these authors really wanted to do something that was simultaneous in 9 different countries. So there are a lot of different methodological guidelines and best practices about how to do this, but sometimes we see questionnaires that are just used by translating them, not following any of these methodological guidelines, and also not without verifying the psychometric properties in the target language in the target population. So that's one of the challenges that we have, also because many of the first HIV questionnaires were really developed in the United States in the late 90s. So a lot of studies that we'll see actually have are using questionnaires developed in 1996 on a completely US population. So one of the ways of overcoming that is something we call cognitive debriefing. And this is one of the times in the process where patients are also involved. And it refers to the process where the questionnaire is actively tested among representatives of the target population and the target language group to determine if the respondents understand the question in the same way that the original question was understood. So in the case of this questionnaire, we see a co-development in English and French, and then translation into the other languages, but then with cognitive debriefing when each of those individual questionnaires was then followed up. Now, the last stage is this piloting stage where you have a cross-sectional study in a limited number of patients to start looking at the factor structure. That means how the different concepts that you're trying to measure, meaning the different dimensions of quality of life, come out in the different, the questionnaire is broken down, and the validity and the reliability, like I mentioned before. Now, I just want to zoom in and dig a little deeper in this initial process because it really is the most important step, ensuring that the questionnaire is valid, and it's also a step where patients can really be involved. On the other hand, it is very time consuming. So I just wanted to show you what the methods were in terms of the qualitative research in the development of their interview guide. There was 102 semi-structured questions. These questions covered topics like self and body care, daily activities, physical activities, health perception, energy, fatigue, cognitive function, social relationships, emotions, and treatment. And at the end of these different interviews, patients were asked 5 open-ended questions to understand impact of HIV on daily activities and quality of life. And that was really to see if anything else came up that wasn't identified through the literature review or previous studies. And that's also one of the challenges that we have in the field of HIV, is that treatment has evolved so quickly, research quickly becomes outdated, and given the time it takes to develop these instruments, that can be a challenge. So on the right-hand side of the screen, you have a sense of the number of interviews that were conducted and the mass of data. Now, obviously, this was especially challenging because they were working across countries, but that was picked up very early on in the process. And now they went from the verbatim text, meaning the different quotes that were coming up for the item generation, and they moved from, on the far left-hand side of the screen, you see the 18 empirically grounded themes, and then these were parceled out into 11 broader themes. So at the bottom of the screen, you have the example of treatment, satisfaction with care, and resources. So that theme is now called treatment. But you're going to have questions within that theme that refer to satisfaction of care. And so at this stage in the process, the authors describe what they developed was a draft or source questionnaire, which included 70 items. So it's still quite long in terms of time it would take someone to complete this questionnaire. So now we get into really what we're talking about here. So here we have a sense of those different themes that we just saw, because sometimes, you know, you see a theme that says coping and you don't really understand what type of question is really being asked. So here, you know, you have the theme sleep. Have I had any difficulty sleeping? And what you don't see on this slide is the type of responses. So generally, they use a type of scale, a 5-point or Likert scale. And for this example, I have had difficulty sleeping. We would have never, rarely, sometimes, often, always. Now at this point, you get to the part where it's the psychometric validation studies. Now this is really critically important. Using an instrument that doesn't have a published validation study is already a red flag. And this is something that's been flagged in the guidance provided by the FDA. So if you're ever involved in any sort of trial development protocol committee and you see people talking about developing non-validated questionnaires, coming up with some questions, that often is a red flag, because sometimes that's done, but it's not particularly helpful down the line. So I wanted to just highlight some of the methods of this study. So it involved 826 HIV positive participants from 9 centers and in 8 different countries. And one of the key sort of ways in which these questionnaires are validated is by comparing the newly developed questionnaire in the different dimensions to other validated questionnaires. And the demographic information is especially important, because we need to also develop guidance on the interpretability and their responsiveness. So how are these quality of life scores corresponding to different disease states? Now, this particular questionnaire was first developed as a paper-based questionnaire, and then it was developed as an online version. So this gives you an example of how the online questionnaire looked, and this is the English language version. And then generally speaking, there are instructions that are given to consider a window of time, right? And one of the particularities of this questionnaire is that there is a lot of mention of how HIV affected different aspects of your life. But in order to, the window of time aspect is especially important, especially in a clinical trial setting, is that you want to be able to see a change over a short period of time, or a change before and after some sort of intervention. Now, this is generally the way in which these scores are presented in a psychometric validation study. Here, the authors describe the way in which now before we were referring to 11 dimensions, and now we're looking at 8 factors plus general health. And we're looking at these across different countries, and the dotted line in the center of each box represents the mean overall country score. So you already see what you see is very interesting, because you see that the patterning is quite similar across most countries. The top left is the Khmer version, so in Cambodia, Senegal, Thailand, the US, Australia, Brazil, China, and France. And so you see some differences in terms of between Australia and Cambodia, and between China and Thailand quite easily. And that you see that some of the dimensions are more marked in Senegal, which during this study, some of the participants weren't necessarily on treatment, and a fair amount of them were stage C. So the questions that we'd ask during the psychometric validation study is, we'd say, so what is there evidence of validity, reliability? You know, can this instrument be used in different settings? And is it acceptable? Sometimes we'll refer to different ways in which concepts had to be adapted, and which factors are the most represented. But however, the last point that's important to know is that responsiveness for this particular instrument is still unknown. Now, this was as I think you may know, there's a fair amount of literature out there on quality of life in people living with HIV. It's not necessarily a new topic, but obviously one of the evolution of treatment for people living with HIV has evolved so quickly that studies evaluating quality of life from the early antiretroviral therapy days are no longer as relevant. Now, this particular review by Vanessa Cooper looked at quality of life studies that were published since 2000. And what she found was that there were 2 generic scales that were used, and that 7 scales were HIV specific. Now, the MOSH HIV scale was developed, like I said, in the early days, and it was only developed in the US. However, it's extensively used and has very good and established psychometric properties. Two additional scales are also, she concluded that two additional scales are also promising. One is the PROQOL-HIV breadth, which was developed from the generic quality of life instrument developed by the WHO using a similar sequential process across several different countries, and then the PROQOL-HIV, which is what I've just presented. Now, there's still further validation is still needed. And then the last point here is just that the choice of the scale needs to always be a function of the specific research question and the end use. And these two scales that are otherwise promising are still missing that data on responsiveness. So in terms of how this data is being used in drug development. So here I want to take a step back and reflect on where patient-reported outcomes fit in the patient involvement in medicine R&D. So what we have here is a slide that I've borrowed from the European Patient Academy on Therapeutic Innovations, and which many of you may know. Now, this is a really interesting slide because it goes from the research priority setting, which I'm sure the EATG is very familiar with, but also to the study design and planning, the research conduct and operations, and then the dissemination of post-approvals. Now, the two little purple arrows on the screen refer to the moments in time where the PROMs become relevant. Now, what I've just presented is important because the patient involvement in the design of the protocol and the inclusion of valid, reliable patient-reported outcomes that are the most appropriate for the time window in question and the research question are especially important because if this isn't included in the design of those initial clinical trials, it cannot be part of the health technology assessment later on. And we'll get into why that's the case. Now, patient-reported outcome instruments have been used in clinical trials in HIV-infected adults. This particular review is looking at an RTI-based therapy over the last 10 years by Simpson and colleagues. Now, they're convinced that patient-reported outcomes may provide valuable information to clinicians and patients when choosing that initial therapy. And they wanted to identify and classify patient-reported outcome instruments used to measure these treatment effects. And what they found was that there were 27 validated instruments that were administered in 26 unique trials. So often more than one instrument was included in the different trials. And although there's a fair amount of diversity in terms of the instruments used, they found that 65% had at least one multidimensional health-related quality of life, and then other instruments that look to measure sleep, depression, anxiety, or psychiatric symptoms, beliefs about medication, and stress. Now, this is a very interesting table because it summarizes one domain, which is depression. And this particular table shows evidence of the use of the CESD scale, the Center for Epidemiological Studies Depression Scale, in two different clinical trials. Now, in the first case, what we see is that the way in which the CSD was administered at week 0, 4, 8, 12, 18, and week 24, but that unfortunately the patient-reported depression scores weren't reported in this particular study. On the other hand, we see in the subsequent study, in the subsequent summary of studies, that this information was actually valuable, that we see improvement of neuropsychological performance from baseline and over 3 years' time. We see a significant decrease in depression symptoms over the course of the study, or the long-term efavirenz treatment treated group, where you see a decline in these scores. Now, just because we have reported this information doesn't mean that there aren't a host of ongoing methodological debates about how to use these instruments in clinical trials and how to, and the appropriate statistical methods and the way in which you interpret just even statistical change. So what the authors concluded in terms of several of these challenges was that there was a noticeable lack of consensus about studies on specific instruments utilized to measure each concept. Here we see, you know, a part of a table that's using the same scale, but if you look at the entire paper and the different trials that were included in this paper, we see a lot of diversity in other domains. And so some of the additional information that's lacking is that authors need to be able to weigh the advantages and the disadvantages of each instrument, and to ensure that, you know, sensitivity and specificity are balanced, and that the instruments that we choose maximize the ability to capture differences that are actually important. Now, in terms of generic PROMs, obviously, there's a tendency to use these instruments, like I said, because sometimes, you know, they can be very easy to administer. The EQ5D is only 5 questions long, and so it takes no time to administer, and there's a lot of promising psychometric properties. Now, is this instrument the most appropriate for certain HIV drug trials? I think that that's something that remains to be investigated, but there is, it might be less sensitive to or responsive to changes that occur over a relatively short period of time. So if, depending on the length of the trial and the state of health of participants at baseline, these are important questions to consider. Now, I just want to take a little bit of time to discuss a trial that I think everyone knows, which is the START trial. And we know that we were looking at immediate antiretroviral therapy compared to deferred therapy. And the primary composite endpoint was any serious AIDS event, serious non-AIDS related event, or death from any cause. And we all know the conclusions of that trial. Now, what you might be less familiar with is the assessment of quality of life in that same trial. Now, quality of life was assessed in the START trial using a visual analog scale for the assessment of overall current health, and the SF-12, which is a generic instrument, and that covers 8 different domains. And you can take the SF-12 and you have a summary physical health score and a summary mental health score. Now, the conclusions of this study were that the quality of life was more or less favorable, and that obviously the early initiation of antiretroviral treatments didn't negatively impact quality of life. But somehow these results are a little bit underwhelming, because the overall health of the population was generally good at baseline. Now, I want to conclude with some guidance that I think really will be useful and set up an interesting forum for discussion about how patients can be more involved in PROM development. Now, this is from the EUPATI website, but I thought it was really very comprehensive, and I think it can, open up some avenues for discussion. So obviously, patients can be involved in evaluating and reviewing PROMs. They can use the information they gain to inform other patient groups about which scales are relevant. They can be involved in identifying the need for PROMs, as we just discussed, and the FDA has taken some leadership on this area, and I provided a link to their guidance on this point. One of the points that I've raised in this talk is now mentioned here. So the developing and evaluating conceptual or theoretical frameworks. So that's the qualitative research that I described with patients, and so really insisting that the psychometric studies and the development of these instruments, that we look back and we take a look at that patient population that was involved in the development, and we have a thought about is that still the relevant population, and how can we be involved in future work. On the other hand, I hope to have stressed that work is quite time consuming to do well, and so we all have to be conscious of that. The patients can also be involved in providing concepts through PROS awareness. I think that this seminar is a good example. And then endorsing PROS and PROMs. This is something that I haven't seen done very much in the HIV world, to see patient groups reviewing and endorsing PROMs, but it might be something that that is taking place in cancer research, for example. And highlighting the need. So I think that some of the work that sometimes is not often done is looking at just the actual items of the questions. We often focus on the psychometric properties of questionnaires, and we sometimes forget to go back and look at what we're actually asking. But that step can provide a lot of insight into whether or not we think a PROMS instrument is valid. Now, in terms of, and that also applies to the reviewing of the health technology assessments, because often we talk about submissions to authorities that involve cost effectiveness or cost utility analyses, and we're looking at cost per health related quality adjusted life year. Now, obviously, the number of instruments that measure utility for those analyses is somewhat limited. So that's something that we also have to take into account, and thinking about how relevant that is. So here are some of the further resources, and I would like to thank you all for your attention, and I'd be happy to answer any questions that you might have.
Thank you very much, Diana. Very comprehensive. I understand that you are probably worried by time, because there are a lot of concepts that need further development, further investigation. But we have a couple of questions from Giorgio. Giorgio, would you mind if I unmute you so you can ask your questions directly? You are unmute now.
Sure. So I had a couple of questions coming up during the presentations. I think the first question was already integrated in your last slide, when I was asking more about what could be other benefit of using integrating PROMs in clinical trials, as for instance having a more economic based evaluation of cost benefits of new drugs entering the market. Are you aware of any other benefits other than quality of life or economic, or the economic impact that PROMs could bring in the research?
Thank you so much for that question. I do think that there are, I mean, in the cancer research where this is probably the most advanced, one of the reasons why quality of life and other patient-reported outcomes became so relevant was because the trials that were being conducted were showing such modest gains in survival that people started becoming interested in trying to distinguish between different treatment strategies by using that patient-reported outcome data, and that became especially relevant. I think that in the case of in case of HIV drug development, I certainly think that if we're looking at side effects, and if we're looking at sleep issues, insomnia, mental health issues, or digestive issues, I mean, sometimes you see. I was looking at recent trial results where you look at the adverse events. And yes, there's no difference in the two adverse events. So if you're going to try and push for new therapy that's equally effective on the classic outcomes, but then also is better tolerated in terms of other outcomes, I think there definitely is scope for pushing for these outcomes to be included and done so in a methodologically sound way.
Thank you. I also have a second question regarding how PROMs could be extended to other measures of quality of life, because other than adverse events, I was wondering whether there are studies or there is interest in researching on how the new drugs could impact the other social aspects of quality of life, like stigma, or improve the visibility of people living with HIV. I'm thinking, when I was asking this question, I was thinking about the new long-acting formulation entering the market that could have this kind of impact on the life of the people.
I mean, I think that there are symptoms that we're all sort of familiar with in terms of, you know, insomnia or cognitive function or mental health, and then there are other areas that have been evaluated in the field of HIV research that relate to satisfaction. And one of the things that I'm looking at in my study, which is trying to understand, well, this isn't as relevant to the cases that you're mentioning, but maybe for a different patient population that's concerned maybe about drug-drug interactions, is treatment burden.
Yeah, as well.
And so that's a generic questionnaire that we're interested in implementing in the study that I'm involved in, where we're trying to understand, as people age with HIV and they're taking other medications alongside their HIV medications, is there a treatment fatigue, a treatment burden? And that's in the context of multi-morbidity. In terms of, and I think probably there's definitely scope for developing new instruments that are able to take into account stigma. And I'm aware of one instrument that's potentially being developed at Johns Hopkins, but I don't think that the validation study is complete yet.
Thank you, Diana. We have another question from Apostolos, but before Apostolos' question, I would like to clarify one thing about patient involvement in PRO's development. So you explained that in the very first part with the, so to say, the first approach to understand what are the items to be investigated. So patients are usually involved. There are interviews, semi-structured interviews, so they can provide input to draft a first testing questionnaire. Then in the subsequent steps of the process, my understanding is that patients are involved only as test responders of the draft questionnaires for linguistic or psychometric validation. but not really involved in discussion about the development of the tool itself. Could you please clarify if I understood well or not?
In the particular example that I presented, I don't think that patients were as involved in that step. However, that's not to say that in other cases there haven't been patient representatives throughout the entire process. Now, in the case of my particular study, we have a patient representative on the scientific committee. And so every meeting that person is invited, every communication they're involved in. And at some point, you know, obviously the involvement of the representative of the patient in those stages, I think probably happens on a case by case basis, depending on also the qualities of the patient representative.
Okay.
But in that particular example, I don't think that there was as much patient involvement in that particular stage based on the presentation of the development paper.
Okay. Apostolos, are you able to unmute your line so you can ask your question, or do you want me?
Yes.
Yeah. Okay.
So in the area of HIV, we are working with various subgroups of patients like IDUs and MSM and other groups. My question is, are these different and various socioeconomic issues faced by these groups? Are they taken into account in a way in these questionnaires? Are they standardized to these specific groups?
So one of the points that you're mentioning is actually quite interesting. So depending on the questionnaire that you choose, different domains are going to be highlighted. So if you choose the 5Q EQ5D questionnaire, you're going to get domains that are focused a lot on physical aspects of health. So if you're interested in more social aspects of health, there are other questionnaires like the one that I'm using, which is the WHO questionnaire, which does have a dimension on social and environmental health. So that can be picked up there. And in terms of understanding how different scores compare in different groups, that's something that's generally done during the validation study to understand if it's sensitive to those types of changes, either things that we, you know, hypothesize to affect quality of life, and to see if, you know, we're looking where we have a questionnaire that you can actually detect sort of differences between groups, if that's something that you're interested in. Now, in the validation of the questionnaire that I presented, there is some discussion by the authors about the challenge of how to, you know, co-developing a questionnaire is obviously a great initiative, as you know, the divide in terms of access to treatment gets smaller and smaller over the years. But at the same time, you see how challenging it can potentially be to asking questions that are relevant to French patients and Senegalese patients, some of whom have had experienced much more severe disease stages and have economic circumstances that are quite different from those in the US or Australia or France. And so their perceptions of quality of life and different concepts that people are trying to elicit through these questionnaires might be quite different. One of the points that was mentioned was that some of the patients in the Senegalese population involved in the study weren't on treatment, so the dimension on treatment couldn't even be evaluated in that patient population. So I think it's both a nice initiative to try and develop something simultaneously so that you have an instrument that can be widely used and used between countries, and you have a quite diverse group that's validated and been involved in its development. At the same time, you know, are we potentially missing out on something that would be more relevant to people in Europe because we've made that choice? And I think that that's almost a political one, actually.
Thank you. I must say I have a lot of questions, so I will do my best to choose among them. But first of all, this question also involved the issue of intellectual property rights, because I know that many of these tools are not publicly available, but you must pay in order to have access to them. In any case, is there any database to understand which tools are available and have been validated?
Indeed, there is a database that that has been set up, and a lot of what's currently recommended in all of the guidance for researchers that are involved in developing quality of life and other patient-reported outcome instruments is to make this publicly available. And so usually I can provide those details. I'm actually not remembering what the name of the website is off the top of my head, but you can often get access to a sample questionnaire. You sign, you're explicit about the context in which you want to use it. If you're using it in a public context, often it's free. Sometimes there's a small fee if you're working on a funded study, and if you're working, and then there's often a price for industry studies. So there's been a major effort to try and make as much and really centralize the instruments that have been developed. And generally, best practices is to make them publicly available. The other option, if you're encountering a questionnaire that you'd like to use or you would like more information on, is obviously to contact the first author of the validation study. So sometimes you have to take that route if you're unable to find the questionnaire through one of these services that's managing its distribution.
Okay. Another question. You said that the process of developing a PRO tool takes a lot of time. So, for example, the PROQOL-HIV tool was started in 2006. Now we are in 2018. So, I think that also the factors as addressing the quality of life of people living with HIV changed in this time. So how can these tools adapt to the changes over time?
I think that's where I think you find a lot of people maybe trying to compromise by capitalizing on existing tools. Obviously, that was a very well-funded study. The WHO. The WHO tool was developed in a similar fashion, but what differentiates the WHO tool from the PROQOL tool is that WHO took a generic instrument that was already developed in a broad population, so that was just general health-related quality of life, and then tried to add a few questions onto that instrument to try and make it more relevant to people living with HIV. But I hear what you're saying about obviously the timing. I think that it's tricky because the PROQOL-HIV is actually one of the more recently developed tools, and when you actually look at when it started in 2007, you're asking yourself the question if we did the same qualitative research starting today in 2018, how different would it be?
Yeah. That's the point. I understand. I want to take 1 minute more to ask you my last question. Should expert patients be involved in PRO's development, or rather, so to say, normal patients? You know what I mean. I mean, there are different aspects of different contributions that can be made there from different type of patients.
I mean, I think that when you're talking about I think that when you get down to it, you're talking about day-to-day issues that you're facing living with a disease. Of course, maybe expert patients might be a bit more attuned to these issues, but they might also be the ones who are the most well cared for, the most active in their own care to begin with. And so maybe if you're only focusing on expert patients, you might be missing out on some of those who just are maybe more in the middle in terms of standard of care that they're receiving and their ability to advocate for themselves. And So I think that it's really important to get as average patients as possible and as much diversity as possible when you're doing that initial qualitative research step. But that's not to say that expert patients don't have a role to play in the process.
Okay, thank you very much, Diana. I think we are over time now. It's 7 o'clock, so thank you everybody for attending this webinar. This has been recorded and will be available. We will send out the link to listen to this webinar if you're interested. So thank you very much and have a good evening.
Thank you very much.